Everyone and welcome. I'm Raghav Sundar. I'm a GI medical oncologist, and I'm very pleased to host this Center for GI Cancer CME webinar series. Every year we host a webinar series. We select the top topics of the year. We typically have 4 topics, and we have these monthly, usually starting in February and going on through into the late spring or early summer. This year, we've selected 4 different topics that we felt Yale had domain-specific expertise in GI cancers. This session is going to be on rare GI cancers. Next month, we have a session on colorectal liver metastases that's going to be led by Dr. Jeremy Kortmansky. In April, we're going to have the biliary tract cancer session that's going to be led by Dr. Jackie Gaddy. And in May, we're going to have the pancreas cancer session led by Dr. Jill Lacey. But today, I'm really pleased to have 3 absolute experts in this field who are going to be sharing with us a different set of rare GI tumor types that, while rare by a big sort of numbers perspective, we actually see a fair number of these patients in our centers, being a subspecialist academic medical center specializing in these tumor types. So first, we're going to have Dr. Thejal Srikumar. She's an assistant professor of medicine from the Department of Medical Oncology and Hematology. And Thejal's going to talk to us about anal cancers. After that, we're going to have Professor Kiran Turaga. He's a professor of surgery and chief of surgical oncology and an expert in peritoneal surface malignancies. And he's going to share with us his expertise and knowledge about appendix cancers. And lastly, we're going to have Dr. Steve Lattanzi, who's an assistant professor and medical oncologist who practice in the Waterford Care Center. And he's going to share with us a little bit about an update in small bowel cancers and some of the work that we are doing at Yale in this space. Because these are 3 different tumor types, we're going to do a Q&A after each of the sessions. Please feel free to put your questions into the chat, and we can answer some questions. And with that, without any further ado, I'm going to turn over to Dr. Srikumar to speak to us about anal cancers. Thejal.
Thank you so much, Dr. Sundar. It's my absolute pleasure to be here with you this evening and to share with you about advances in anal cancer with a specific focus on updates that we've seen in the last year. I have no disclosures related to this talk. And in the style of ASCO, I would like to start with our key takeaways with what I hope you're walking away with from today. So the first is that chemoradiation with 5-FU and mitomycin remain the standard of care of treatment for locoregional anal squamous cell carcinoma, although investigation is looking into whether we can move immunotherapy in this setting and whether we can optimize radiation dosing. The second takeaway is that we can use potentially ctDNA to better surveil our patients after their initial chemoradiation. And the third, which is bolded in yellow because this is practice changing, is that we now know that the new standard of care is we should add retifanlimab to carboplatin and paclitaxel in patients who have metastatic anal squamous cell carcinoma. So starting with some big picture background, we know that anal cancer is rare, but is on the rise. And how rare is rare? Well, if you look at the SEER data, there are approximately 10,000 new cases a year in the United States, about 30,000 new cases globally, which represents about 0.5% of new cases of cancer every year. But we do see in the SEER data that there has been a rise in the rate of new cases at about 2.7% per year for somewhat unclear reasons. I do want to acknowledge that there are multiple tumor types that can happen in the anal canal, including adenocarcinoma and neuroendocrine tumor. But for the purposes of my talk, I'm really focusing on squamous cell cancer, which represents about 90% of these anal cancer cases. It's important to note that we don't treat anal cancer based on the location of the tumor in the anal canal, but rather the underlying pathology. So, for example, if you have an adenocarcinoma that is present in the anal canal, we would treat that more similarly to a rectal adenocarcinoma. We know that anal cancer is associated with HPV in about 90% of cases, particularly the high-risk strains such as 16 and 18. And what we find is that as the HPV viral production is ongoing, we have an increase in the E6 and E7 oncoproteins, which disrupt P53 and RB regulation. We see that the viral genome is integrating into the host cell DNA, and all of this is causing immune escape and also and tumor microenvironment changes. So eventually, what we're seeing is transition from what was originally normal tissue to higher grade dysplasia and eventually to invasive squamous cell carcinoma. And as we do know, we have vaccine recommendations and guidelines, as well as screening recommendations for populations who are high risk, particularly those who compromised. We are still seeing the rates on the rise, as you saw in the last slide. However, my hope is that we just need more time to see the effect of our public health interventions. Regarding staging of anal cancer, a new version of the AJCC staging guidelines came out in 2023, and this still uses the TNM staging system, but I just wanted to distinguish anal cancer staging from colorectal cancer, particularly in that T stage represents the size of the tumor as opposed to the depth, and N stands for the location of the lymph nodes as opposed to the number. And another key factor in the updated version of staging is that previously in the 8th edition, we saw that nodal positivity meant that the stage was classified as 3. However, in the newer version in the 9th edition, we see that you could have smaller tumors with node positivity and be classified as stage 2B. And this change occurred primarily to match our staging prognostication with the survival curves. So here is a depiction of the survival curves per the AJCC 9th edition staging. And what you see here is that localized cancer still has quite high survival, but this does drop off with bulky tumors and more nodal involvement. And in patients who have metastatic disease, the survival is still quite poor in the 20 to 30% range. So how are we treating anal cancer? This is a timeline of treatment in local regional anal cancer over the last several decades. I fully acknowledge that the text on this slide is quite small. And really the reason why that I'm not too worried about it is because what we really need to pay attention to is the first point on this timeline. Back in 1974, when we first got the report from the NIGRO, what we call the NIGRO protocol and the Wayne State experience, which looked at chemoradiation as an alternative method to APR surgery in anal squamous cell carcinoma. And all of these studies since then have looked at potentially swapping out chemotherapies or omitting chemotherapies, and really nothing has been able to beat a version of this original regimen in terms of outcomes. So when you look at the NCCN guidelines, you find that the first line is still 5-FU mito plus radiation with the option of switching out the 5-FU for capecitabine. And this is because the outcomes are strong. We see the 5-year overall survival and the colostomy-free survival in the 70 to 90% range. But we also know that the toxicity in this regimen is quite high, in over 50% of grade 3 toxicities and higher. So what's new in the last year to try to help us update this treatment that we've had for years and years? We've seen some new data looking at whether there's a role of moving immunotherapy to this early stage setting. And the interaction trial was just recently published evaluating this question, as well as other trials which are still forthcoming in their data publication. But to give just a big picture, bird's eye view look at what the interaction study is, it was a phase 2 single arm study of stage 3 anal squamous cell carcinoma in a small number of patients. And it looked at induction chemoimmunotherapy. So docetaxel, cisplatin, and 5-FU, plus a PD-1 inhibitor as a benlimab, followed by chemoradiation, which was tailored depending on how their response to induction was. And what the study found was that there was a high rate of pathologic and near complete responses with a low rate of colostomy need. The survival curves looked quite similar to what we have in terms of our standard of care. And a large percentage of populations still did have grade 3 or higher toxicity. So, what do we take away from this? What the authors are saying is that while there are similar outcomes to our existing regimens, the patients who were included in this study were all stage 3. So they were higher stage than a lot of the other studies that have looked at our standard of care. But importantly, there was no comparator in this study. It was a small number of patients, and we need long-term follow-up. There are a number of trials that are coming out, which is very exciting, looking at immunotherapy either concurrently with chemotherapy or after chemotherapy. The Tirana study reported some initial data at GI ASCO 2026 just last month, and we are awaiting the ECOG Akron 2165 trial, which is a randomized phase 3 trial looking at nivolumab after chemo RT, which hopefully we'll have data for soon. So, is there a role of immunotherapy here? We don't know yet, but maybe. And then the other part of this is the radiation. And so in the last year, we've seen some more data about whether or not there's an opportunity to optimize our radiation dose in this setting, whether it's to de-escalate or escalate depending on the risk. And again, big picture, bird's eye view. The Plato Act 4 study was published last year looking at de-escalation. This was a study of early stage anal squamous cell carcinoma and randomized patients either the standard dose of radiation or reduced dose with our chemotherapy backbone. And the big picture takeaway was that there were similar complete clinical response rates with less toxicity in the lower dose arm. So there's hope that maybe we can use a de-escalation strategy here, although we don't have the 3-year local regional failure or long-term outcomes yet. On the other side of this spectrum, at GI ASCO 2026, the Plato Act 5 study was presented, which looked at patients who had higher risk anal squamous cell carcinoma and randomized to 3 doses of escalating radiation with chemotherapy. And they found that the toxicity rates, even with the higher doses of radiation, were about similar, but so were the clinical complete response rates. It didn't show yet, at least, that there had been improved outcomes with increasing the radiation dose. So again, we're waiting for long-term outcomes, but at this point, we still use our standard dose of radiation, although I think particularly there's hope for de-escalation strategies moving forward. We did also see last year that ASTRO published guidelines for the first time for radiation oncologists for the care of anal cancer as well. Moving to surveillance after this initial treatment of local regional cancer, these are the NCCN guidelines, which recommend starting surveillance at the 8 to 12 week timeline after the treatment completion. And the modalities are primarily inspection, palpation, anoscopy, and imaging. It is very important to note that you can have continued regression of anal cancer even 6 months after the completion of your treatment. So particularly, it's important not to biopsy too early unless you have progressive disease. Local regional failure rates are about 10 to 30% and are primarily managed by abdominal peritoneal resection. And unfortunately, the outcomes when patients do have local regional failure are not great. The range of overall survival is 40 to 60%, depending on what study you look at. So there have been more recent studies looking at the possibility to improve how we are following our patients to see if we can intervene earlier and capture the patients who might be developing recurrent disease earlier. And this last year, we've seen some new data on ctDNA in the local regional anal cancer setting. And we've seen data both in 2 different types of ctDNA. One is tumor-informed and another type is HPV-informed. So this was presented at ASCO last year, and this is a tumor-informed assay, Signatera through Natera, and a single institution study which looked at following tumor-informed ctDNA in the pre, mid, and post-treatment as well as surveillance setting, and 80% of patients had positive ctDNA pre-treatment. And they did find that early clearance had better overall survival, progression-free survival, local regional failure. But I think a question that we have for a lot of our GI cancers is, what do we do about this data and how do we intervene? How can we help these patients who do have ctDNA positivity? And last year, there was also a publication from MD Anderson looking at HPV ctDNA, again, pre and post treatment and with surveillance, with 68% ctDNA HPV positive in the pre-treatment. And you really see these quite striking separation of curves of the recurrence-free survival between patients who were positive and negative at the 3-month or greater time point, with those who are positive having a recurrence rate of 80% versus 2% in the negative. Again, this question remains of what do we do about this information? So I think that moving forward, we might be able to utilize this data once we have more studies, knowing how we can intervene upon it, but not quite yet. And this is where I want to spend the rest of my time. And there's a big gold star here because, as I said in the beginning, this is practice changing how we approach advanced anal cancer. We know that a small percentage of anal cancer is metastatic at diagnosis, about 14%. And the prior standard of care was based on the phase 2 INTERACT study, which showed improved overall survival when using carboplatin paclitaxel versus cisplatin 5-FU of a median overall survival of 12 versus 12.3 months. But we now know that there is a role for immunotherapy frontline in patients who have metastatic and advanced anal squamous cell carcinoma. And this is based on the Podium 303 Interact 2 trial. And there are other still trials that we're waiting to see the data from. But I did want to spend a little bit more time in details about this specific trial since it is practice changing. So this trial was phase 3, double blind, and a global study. And it evaluated randomizing patients to carboplatin paclitaxel and either placebo or retifanlimab, which is an anti-PD-1 antibody. And this is the study schema, which shows the one-to-one randomization that was stratified by PD-L1, the region of the world that they were treated, and the extent of disease. And patients, the design of the protocol was to receive 6 months of carbotaxol and a year of retifanlimab with the option to cross over if progression was seen. This is the breakdown of who was included in the study, and we do see that the majority of patients were older and female, which does match the majority of our patient population. However, I do want to highlight that the large majority of patients were identified as white, with a few percent that were Black or African American, Asian, or other. So again, the translatability to who we're actually seeing in clinic comes to question here. The majority of these patients did have a positive PD-L1 expression, which was defined as greater than or equal to 1 at 91%. And what we do see is that the overall response rate improved from 44 to 55%, with the complete response rate of 34% in the carbotaxol plus retifanlimab arm, and a doubling of the duration of response. They met their key primary endpoint, which was PFS, which improved from 7.4 to 9.3 months. And the newest information was presented at ESMO IO last year in December 2025, which showed a marked improvement in median overall survival from 22.2 months to 32.8 months in the patients who received chemoimmunotherapy. There was a high rate of grade 3 adverse events and higher in both arms. But based on this study, last year, the FDA did approve adding retifanlimab to carbo and Taxol for the first-line treatment of metastatic anal cancer. The question does come up of whether or not we can substitute another PD-1 inhibitor for retifanlimab. We don't quite know that yet. We are also awaiting the results of the ECOG-ACRIN 2176 trial, which is evaluating the addition of nivolumab to carbo and Taxol. So, in summary, anal cancer is rare but on the rise, and outcomes, particularly in the advanced setting, are remaining poor. And we need better investigation to improve prevention, early diagnosis, surveillance, and therapies. I didn't even highlight the exciting ventures that are going into the possibility of cellular therapies and vaccines that are starting to look particularly in these HPV positive cancers. And again, these are my key takeaways that still we use 5-FU and MITO with radiation for treatment of local regional anal cancer, but there may be a role for immunotherapy or dosing changes of radiation. We might see a role for ctDNA in surveillance. And importantly, we now add retifanlimab to carbo and Taxol in the frontline setting. So thank you so much to all of you for your time and attention, and a huge thanks particularly to our GI team here at Yale, who I'm so grateful to be a part of. And I'd be happy to take any questions, and feel free to reach out to me afterwards as well.
Thanks, Dr. Srikumar. That was really a great talk. I'm going to encourage folks to put in questions into the chat. And while we're waiting for questions, I've got a question that I'd like to ask was, or rather, before we start, the question was, I think at Yale we've already started to use retifanlimab with carboplatin and paclitaxel. I just started a patient a couple of weeks ago, and I think Dr. Zhang in the audience has also started a patient. So it is something that's quite exciting. So first question is, I think you started to address this, but retifanlimab's a new anti-PD-1 inhibitor, but we don't really know whether it's going to be different from any other checkpoint inhibitor. Would you recommend that we could use this interchangeably at this point of time, or do you recommend sticking to retifanlimab?
Yeah, that's a good question. I think since retifanlimab is what we have the data on, ideally, that's what we would still use. Whether we could extrapolate and switch to other PD-1 inhibitors, I think it's reasonable, though we don't have the data yet. I do think that it is coming soon, with especially the ECOG-ACRIN trial coming out. I probably would not swap out for a PD-L1 inhibitor like an atezolizumab, but I think Nivo and Pembro could be reasonable, particularly if there are settings, for example, when insurance isn't approving this treatment. Although now that it's FDA approved, hopefully it wouldn't be an issue.
Thanks. I think more than insurance approvals is going to be pharmacists, and we have a lot of pharmacists in our audiences. They need to get this new drug into the formulary, and while we have it at the bigger care centers, I think it may not be easily accessible into the community for everyone to get a third or fourth or fifth PD-1 inhibitor in medicine. I think that's the question. Another quick question is, do you think that there is hereditary component to the anal cancers that is something that we should be looking out for? Would you recommend germline testing and referrals and that sort of thing?
That's a good question. It's not a disease that we typically associate with, hereditary cancer syndromes, particularly because for squamous cell carcinoma, so much of it is related to HPV and the other risk factors that we know about. However, along with this rise in incidence of other early onset GI cancers in the young adult population, we are seeing that in anal cancer as well. So is there something germline that is going on that we have not yet captured yet, whether it's actually in the germline or whether it's epigenetic? I think it's a good question, but we don't have the data to suggest that we need to do sort of broad germline testing yet.
Last question is, do you think that if you use retifanlimab in frontline, would that affect your next line treatment choices?
Yeah, and I see that Steve put that in the chat too. I think that's a great question that we don't know the answer to yet. Previously, a lot of the data that we had at immunotherapy in the advanced setting had been in the second line and the beyond. And so we don't know what to do in these situations quite yet, since this data is new and what the best approach is. But I think if someone had continued on the retifanlimab maintenance and that's what they progressed on, I would be more likely to switch to another systemic chemotherapy regimen as opposed to immune therapy.
Yeah, I fully agree with you. I think across multiple tumor types, there's very little evidence of continuing checkpoint beyond checkpoint. At least just PD-1 to PD-1 doesn't have any benefit. So I wouldn't recommend continuing with it. Thank you, Dr. Srikumar. That was great. We'll move on to the next set of talks. We next have Dr. Turaga, who's going to talk to us about appendix cancers. Kiran, over to you.
Thanks, Dr. Sundar. Thank you, everyone, for joining in the evening or whenever you're actually listening to this. Um, right. My talk is not as structured, I would say, as Dr. Srikumar. She did such a spectacular job in talking about anal cancer. And I'm going to talk a little bit about appendix cancer, give you some key sort of tidbits and highlights of where the field is going, but I don't think by any means is this comprehensive or replaces really just thinking about disease in its entirety. But I hope it'll kind of share some exciting things that are happening in this space. I don't have any relevant disclosures. And so I think the key thing that I wanted to highlight is to talk a little bit about the incidence of appendix cancer and to talk a little bit about causality of appendix cancer. And some of this is unpublished work or work that has been presented, new research. Um, Talk a little bit about treatment planning and what the field has moved towards. It's not specifically going through actual treatments for every patient, but how do you actually think about this disease in its entirety? And then maybe share a little bit about research that's ongoing with us over here at Yale. For the longest time, we thought the appendix didn't have any function. We thought that the appendix was a vestigial organ and essentially did not have any relevance to the GI tract. And we have since, of course, identified that the appendix has two key roles, one in the immune function of the body, and the second in sort of the microbiome and maintaining the microbiome. So you have one of the illnesses, you get diarrhea, gastroenteritis, the appendix actually repopulates the colon with normal bacteria. And why this is important to know is that when you think about what causes appendix cancer, it's very important to understand that appendix cancer is the fastest growing GI cancer for incidence. And this hit the news recently. You might all know very famous people like Katharine Hepburn, who actually died of appendix cancer, or Stuart Scott, who was one of the ESPN news anchors. And this kind of brought this whole field to a little bit of the spotlight. And it's remarkable that the silent generation, or folks that were born in the 28 to 45, the incidence of appendix cancer kept increasing. This is a birth cohort graph that was published recently in Annals of Internal Medicine. But what is fascinating is that for the younger adults, the 40 to 45 range, the Gen Xers and the baby boomers, it's starting to get apparent that the incidence of appendix cancer seems to be increasing almost tenfold in these populations. And so, of course, the big question is that what is this happening from? And is this like other early onset GI cancers that is somehow related to our environments? Is this microplastic? Is it microbiome alterations? And we have had two hypotheses that I'm going to share a little bit of data about. One is that of genetics, and this is Nikki Aguirre, one of our residents, who just presented this work actually not long ago, but essentially looking at what is the incidence or prevalence, I should say, of germline mutations or hereditary mutations in patients with appendix cancers. And here you can see the graph splitting the tumors up by the grade of the disease. So whether it's high-grade tumors or low-grade epithelial neoplasms, and what the percentage of patients who have germline mutations. And if you actually look at it, you can see that the purple part of this bar graph is only about 60%. So almost 40% of patients have some version of a germline mutation. Now, the pathogenic mutations, so the known pathogenic mutations, are only about 10 to 12%, which is still quite high. So, in fact, for appendix cancer, to say that 1 in 10 patients has a genetic mutation that is pathogenic, that is associated with appendix cancer, is quite an innovative and novel finding in itself. But it's also interesting that there's another 20 odd percent of patients who have variants of unknown significance, which is higher than, say, like a general population VUS cohort rate. And they have different pathways that they're associated with. So I think, clearly patients with appendix cancer benefit from, in my opinion, some version of testing of germline disease, of germline mutations. I think the other thing that we've also discovered, which is fairly interesting, is that 25%, so a quarter of patients with appendix cancer tend to have autoimmunity as well. And this kind of fits in nicely with hypotheses and work done from other groups where they've seen changes in bacteria, there are changes in neutrophils, changes in both innate and adaptive immunity. both T and B lymphocytes changing in appendix cancer in the way they kind of interact with tumor cells. And clearly, we're seeing this more with thyroid tumors. We see this a lot more with obviously ulcerative colitis and Crohn's disease, but also with other autoimmune diseases such as lupus. And so it is something that we've been very intrigued by. This is a sort of very fancy graphic to essentially talk a little bit about our work in liquid biopsy. So looking at 5-HMC to separate patients with autoimmune disease. And if I could just draw your attention to the bottom left panel right here, which is labeled D, you can see that the autoimmune disease positive patients tend to have very significantly differentially hydroxymethylated cytosine or genes that are hydroxymethylated, leading to this you can see a very unusual sort of a plot which kind of separates the autoimmune and not autoimmune populations. And we see a lot of overexpression of some of the cancerogenic pathways in addition to some of the autoimmunity pathways as well. So it's an interesting phenomenon, not well known whether it's causal or not, but certainly associative with it. So I think just if you think about what are the key concepts of appendix cancer. So first of all, it's a rare cancer, but it's still one that has the fastest rising incidence. It occurs in an organ which is highly immunogenic, seems to have an association with germline mutations and autoimmunity. There is a tumor type that tends to have a large number of KRAS mutations, but also has unusual mutations such as PIK3CA mutations that are associated with early onset appendix cancer. It rarely has APC mutations. And so, in fact, if you see a patient with like a tumor in the appendix and there's a cecal mass and you can't quite tell which is which, having an APC mutation generally reduces the possibility or suspicion that this is an appendix tumor. These unfortunately tend to get detected late, and so they often present with peritoneal metastases. These are very distinct phenotypes and phenomena from neuroendocrine tumors, and we're not talking about those today, but they're incredibly misunderstood, and we'll talk just a little bit about some of the concepts here. The other thing, and I think for perhaps the surgeons in the room or the oncologists who hear the word appendix cancer and quickly send patients off to get right hemicolectomies, the right hemicolectomy is not always indicated for many of these tumors, especially the epithelial neoplasms, or especially if it's adenocarcinomas with peritoneal dissemination. And I think it's a very important idea because many times we see patients with appendix tumors, they go see a general or colorectal surgeon and have often had a right hemicolectomy, and it's a huge issue for these patients long term because they end up losing their IC valve. And so it actually puts them at a high risk for short gut and short bowel syndrome. So it is important. We can obviously talk about the nuances of who does or does not need a right colon surgery. Unlike many other cancers, and especially GI cancers, where we rely on one or the other, CEA or CA19-9, or for GYN tumor, CA125, all three of them actually have prognostic value in patients with appendix tumors that have peritoneal disease. The CEA is just like any other CEA GI tract cancer marker. It seems to have association with prognosis. So the higher the CEA, patients tend to do more poorly. They're more associated with mucinous tumors, more associated with signet ring cell disease, but does not indicate any therapeutic differences. CA19-9, on the other hand, when it is elevated more than 100 units per ml, it tends to preclude a complete surgery for patients with appendix cancers. And so it is a nice marker to track for patients. We've also seen this increase when patients have transformation of their tumors, if it ever occurs. And so a nice marker to see. And 125 is clearly a peritoneal marker. So essentially, whenever there's a lot of peritoneal inflammation, we tend to see 125 elevations. I think it cannot be underscored enough that pathology is incredibly important in understanding appendix tumors. And so we'll talk a little bit about it, not comprehensive, but really it's important to think about what are epithelial tumors which are not cancer. So low-grade appendiceal mucinous neoplasms and high-grade appendiceal mucinous neoplasms, even though the word high-grade sits in it, are actually benign entities. These are not entities that are adenocarcinomas. They're not invasive. They're not like classic adenocarcinomas, and these are associated with incredibly long prognosis. But on the other hand, we have goblet cell adenocarcinomas. Quite often they used to be called goblet cell carcinoid that is a term that has been retired because it gave people this false sense of reassurance that these were neuroendocrine tumors that are very slow growing. These are adenocarcinomas with neuroendocrine different or neuroendocrine cells, so they have both of these features in these tumors, but they tend to have a bimodal distribution. Either they get cured with a surgery when they're localized, and perhaps sometimes with systemic therapy in addition to that. But once they're metastatic, these patients tend to do quite poorly. And so it has a very bimodal sort of a prognostic significance. And then, of course, signature cell disease, which we all know and tends to portend a very poor prognosis for patients in general, which have GI cancers. Appendix cancers are one of those few subtypes of GI cancers where signature cell disease is perhaps actually not as bad as even those with more aggressive, such as the goblet cell adenocarcinomas or poorly differentiated or mixed tumors. And so kind of a very unusual pattern of disease for these tumors. I think this is something that we led this effort out of Yale, where a bunch of pathologists from across the country sat together and tried to kind of come together and make some sense of all this alphabet soup we have around appendix tumors and what the classifications are. And what I wanted to share, which is very interesting, is for instance, if you have a tumor called the low-grade appendiceal mucinous neoplasm, many times people call it a mucocele. Mucocele is by definition just a dilation of the appendix with mucin. So if you had a fecalith or you have a stone in the appendix lumen and it dilates up, that's a mucocele. That's not a neoplasm. A neoplasm implies that there is a change in the epithelial architecture. It doesn't necessarily mean that there is cancer. It doesn't mean that there's invasiveness. The basement membrane is often intact, or even if it isn't, it's pushing invasion and it's not actually invasion through the basement membrane into the submucosa. So it's kind of a very unusual tumor from that form. But when it goes to the peritoneal cavity, or if it bursts and spreads to the peritoneal cavity, it has been called everything from stage 4 adenocarcinoma in some WHO classifications to low-grade carcinoma peritonei in SOGI classification to WHO grade 1 in the current WHO classification. So it's a very complicated disease in terms of how we express this to patients, because sometimes patients come out of a meeting thinking they have stage 4 cancer and they're going to die. And indeed, they're actually going to live 20 years because they have an epithelial neoplasm with peritoneal disease. So it's a very important concept to remember that there is a very distinct phenotype, which is a Lamin and a Hammond, which can have peritoneal disease. And even though it's called cancer in some classifications, is truly represents WHO grade 1 pseudomyxoma peritonei. Unfortunately, this classification is again going to get changed. And so stay tuned for details about this. But this is sort of the data where often, we see patients in our clinic who have seen physicians, oncologists, and sometimes really well-meaning doctors and are told, oh, you have stage 4 appendix cancer and it's an epithelial neoplasm. You need either systemic chemotherapy for life or, essentially you're going to die in 3 to 6 months. And in fact, if you look at a lot of series, and there's many other series, but this is a nice paper from Lancet Oncology. It's an older paper, but looking at some of the series of patients with appendiceal epithelial neoplasms, both low grade and high grade, treated with cytoreductive surgery and HIPEC, you can see the x-axis is 20 years, and close to about 70% of patients are alive when a good complete cytoreduction is done. Even when you don't do intraperitoneal chemotherapy, still modest survival. You can see about 20 to 30% of patients still alive at 20 years from diagnosis. So it's a very different disease than perhaps other diseases that we're used to. Now, the challenge for all patients with appendix tumors is the fact that the peritoneum is actually not very visible on scans. You can see that from a coronal view over here, you can clearly see a large liver, you can see organs, you can see the mesentery, but you could barely see what the peritoneum looks like. The yellow lines kind of show what the peritoneum looks like, and this makes it very challenging for these patients because they get diagnosed very late. The other part that is very difficult to appreciate is there's a big difference between the parietal peritoneum, which is like wallpaper on the walls of a room. You can easily clean it out. But visceral peritoneum, where the mesentery of the bowel and the bowel surfaces themselves are incredibly difficult to remove. So that is a big factor for resectability of some of these appendix tumors. And I am speaking a little bit about metastatic disease because that tends to be a common presentation for these tumors. So if you look at, say, a CT scan, like a representative CT scan of a patient with a fair amount of peritoneal disease, big early markers you should look for, aggressiveness is essentially if you have disease by the epicardial nodes. If you see epicardial nodes, 20% of the times they are malignant. They're not always malignant, but 20% of the times they're malignant. But if they are enlarged, they tend to indicate disease in the right diaphragm. I think the key factors that detect resectability is involvement of the porta hepatis right here, as well as a structure called the IVC bursa that occurs between the caudate lobe, the hiatus of the crus of the diaphragm, and that's a big area that if there is a lot of disease, it's unlikely to be completely resectable. Scans like this, where you see extensive amounts of ascites, lots of disease, doesn't mean that this cannot be cytoreduced. In fact, quite often for patients with low-grade tumors, even with PMP grade 1 or even grade 2, these are actually resectable. What really defines resectability is the mesentery itself. So if the mesentery is involved, that's when it makes it really difficult to remove all the disease. The disease burden from the omentum, the appendiceal primary tumor, are actually quite relevant and quite easy to do. And if the tumor has calcifications in it, it is generally pathognomic of a mucinous tumor as opposed to, say, a goblet cell adenocarcinoma or one of the other more aggressive histological subtypes, including mucinous adenocarcinoma. So I think one of the key tools in the management of appendix disease is laparoscopy. For the surgeons in the audience or those that listen to this, typically if you are suspecting a mucinous tumor or mucinous adenocarcinoma of the appendix, try to avoid lateral ports because these patients tend to recur with abdominal wall disease. Again, they have long prognosis, they live a long time, and so they tend to recur along sites where there is angiogenesis, such as your incisions. You clearly have to explore the entire peritoneal cavity. This is a very common clinical presentation we see of these patients where they present with bowel obstructions. This is the location where that occurs. And this is a recess where there is peritoneal disease that tends to occur for these patients with appendix cancer. And they get obstructions. We try to put stents in them. They don't usually work. And so this is a big source of morbidity for many of these patients. And then clearly, of course, the right diaphragm, a very common site of disease because of the numerous high endothelial venules that are present here and the milky spots that tend to cause it. And then over here for an example of what the lesser omentum looks like, where there is incredible amounts of disease. So just like we think of staging of cancers through AJCC, a big part of appendix cancer management is understanding a peritoneal cancer index. This is a measurement of peritoneal disease when these tumors tend to spread. If they're localized, it's actually quite easy. If it's a localized mucinous neoplasm, resection with complete negative margin is adequate. You don't need a right hemicolectomy. Mucinous neoplasm, negative margin resection, you're done. If it's an adenocarcinoma, non-metastatic, right hemicolectomy is of curative intent and generally quite favorable for these patients. So that's a very broad setup of how you treat these patients. But if there is peritoneal disease, the PCI score is incredibly important. And then the other thing, which is kind of a little bit of a pet peeve of mine, people call it debulking surgery. It's not truly considered debulking. C for cytoreduction, C for curative intent. So if the curative intent surgery is called cytoreduction, the goal is to extirpate all tumor that is visible to the best ability possible. Debulking implies going in with an intention of removing less than complete surgery. So there's a big difference between the way we approach these patients, even though the nature of the operations could be quite similar. Really what matters is what is done inside for these folks. So I would strongly encourage all of you to look at these. These are guidelines that were generated out of Yale. This is nationally endorsed by SSO and have now led to the NCCN guidelines that have adopted a large part of these. This is sort of the process that many of our Yale trainees undertook with about 300 odd physicians across the country and came up with the pathway and came up with the workup for this. You can see that in the workup, we do talk about consider testing for germline mutations, so that's important. Colonoscopy is not always indicated for these patients because the rate of secondary tumors is actually quite low for especially epithelial tumors of the appendix. But regardless, we tend to get that until we have better data. I think clearly talking to patients about fertility is very important because many of these patients tend to live quite long, but end up tending to have very aggressive surgeries or aggressive chemotherapies that can actually lead to ovarian failure in females. And so it is important to have those conversations. And then this is sort of one of those pathways that talks about how to take care of these patients. The key concept being if you have an epithelial neoplasm with peritoneal disease, scans can be every 6 months for the first few years and then every year after that, so much less frequent than, say, if they're adenocarcinomas, in which you tend to follow them similar to um, colon cancer. And then this is just kind of talking about how we did this whole process and how we went through this. And then this is a table for systemic chemotherapy. I think the bottom line is that unfortunately, for appendix tumors, we don't have very good evidence that suggests systemic chemotherapy works very well. For low-grade disease, there have been numerous series that have looked at systemic chemotherapy. And while in practice we tend to use they tend to have very low CEA responses, very low reduction in progression of these mucinous tumors. And so typically for epithelial tumors like Lamb, Hammond, and even well-differentiated adenocarcinoma, the role of systemic chemotherapy is a little circumspect. For high-grade disease, I think as a consensus, we all agree that systemic chemotherapy is valuable for patients, even though data hasn't quite shown that completely. But typically, these are treated with colon-type regimens, whether it's FOLFOX, FOLFIRINOX, or FOLFIRINOX plus anti-VEGF inhibition. And the new NCCN guidelines are now out, and so I'd certainly strongly encourage all of you to take a look at those as well for appendix tumors. So in the last few minutes, I just wanted to talk briefly about how we are doing novel things for patients with appendix tumors. We have a clinical trial where we take patients with appendix disease, especially if they're unresectable tumors. We get biopsies, we sequence them, and then we study them. We use this technology called Travera, which is a microchannel resonator with which you can see which chemotherapies they're sensitive to. And then they get systemic chemotherapy every few weeks, and every 6 weeks they get an intraperitoneal chemotherapy with a laparoscopic hypex. So that is sort of one interesting clinical trial that we've just opened. We also are very interested in this idea of using Ibrance or palbociclib, which has been shown for GNAS mutant appendiceal mucinous tumors, whether low-grade adenocarcinomas or epithelial neoplasms, to have a great response. I'll direct your attention to panel D, where you can kind of see that CEA reduction with historical chemotherapy was actually quite low as compared to when you use palbociclib in this cohort of about 20 patients. So it's a small study. It isn't great level 1 evidence, but published in JCO for a fairly interesting result here. And I think, again, we're also very interested in patient-centered care. And this is Rachel Greenup and Liz Godfrey, who've been leading a lot of the research for appendix cancer patients and trying to understand their choices around treatment decisions. And we now have a clinical trial that is in progress or is going through review called Decisive, where we're trying to create a decision tool to help patients navigate these complexities, especially as all of us are trying to understand appendix cancer better. And so I thank you all for your attention. This is my email. I know by no means this is fully comprehensive, but hopefully this provides you a little flavor of what is going on in the field of appendix cancer. And certainly, myself, Dr. Sundar, Dr. Srikumar, Dr. Lattanzi, and all our GI oncology team here are delighted to help you as you think about appendix cancers, and especially if you have patients that you encounter. We're happy to brainstorm with you on how best to take care of them. Thank you.
Dr. Turaga, that is really, really an inspirational talk. And I can say with confidence that before I joined Yale, I'd seen maybe 3 appendix cancers in my life. And in just a year here, I've seen a real large number of patients. And it is a rare tumor type in the community, but the wealth of expertise that we have here, managing them, they do require multidisciplinary care, specialist surgical oncology care, and the rest of the supportive care team that takes care of these patients. Kiran, maybe while we're waiting for, there is a question in the chat about whether you know which are the most commonly identified germline pathogenic variants that we see in appendix cancers. Maybe we'll start with that.
Yeah, so the interesting thing is that we have seen BRCA2, CHEK2 as 2 of the more common mutations. Can you guys hear me okay? I think my video is kind of frozen, but But yeah, those are the common germline mutations we have seen. It was interesting, we had talked a little bit about an MSH6 mutation in an appendix tumor, which was kind of a rare thing, and we hadn't quite seen that, and we recently saw that as well. So I think it's kind of interesting to think about the germline mutations that are present, but lots of VUSs of all, highly oncogenic mutations, germline mutations.
Yeah, I mean, I think it's true that we wouldn't ordinarily think of testing an appendix cancer germline testing, but the more we actually look, the more we're seeing these hereditary syndromes. But a majority of these tumors are still going to be sporadic in nature and not hereditary. Could you share with us a little bit about the reclassification of what very often comes as colon cancer, but when you go in, you very often realize that, hey, this might more likely be appendix cancer than colon cancer. What goes through your mind and what allows you to, and how does it make a difference to the clinic, like the clinical course of these patients?
Yeah, I think it's a great question, and I wish I had a simple answer, but I think, a lot is dependent both on the clinical course and the pathology. So clinically, I think just broad strokes, appendix tumors tend to be slightly more favorable than colon cancers. They tend to spread a lot less to liver and to lymph nodes and to lungs than compared to colon cancer, for instance. So I think when you see patterns of metastases, or if you do see metastases in the liver, in the lungs, in other areas, they tend to be much more solid tumor metastases, tend to be less likely from appendix tumors. Appendix tumors tend to spread a little bit more like the BRAF tumors quite often, where they can go to the bone, they can go to all these bizarre sites, pleural dissemination. They tend to have a lot less solid organ metastases. When you think of the tumor itself, when you do a colonoscopy, it's actually a very important piece of information. Is there a precursor lesion present on the colon side or not? And I think that's a very important part of finding out where these tumors are coming from. Because if there is a precursor polyp, or you see a villus adenoma, or you see something on the colon side, I think then it's a lot more likely that you're seeing this sort of pathway. Otherwise, quite often we think of these as being appendiceal. I think appendiceal tend to be obviously more mucinous, more signet ring cell type as compared to colon, even though you can have right-sided mucinous and colon and signet ring cell tumor colon cancers as well. So it can be confusing in terms of which one is which. But I think generally when I've seen signet ring cell disease and you see a lot of inflammation in the right lower quadrant and you're not really sure which one is which, they've tended to be more likely appendix, and maybe that's just a pattern of my practice. But because you see these signet ring cells, they tend to be a little bit more commonly occurring from that, especially if your patient is well preserved, they don't look very sick, they're doing okay clinically. I think that tends to be a little bit more in that sense. And then I think mutationally, I think we use APC sort of like as a big classifier. KRAS can be a little bit of a classifier, but not enough. I don't think we have enough of a gene signature yet to say, this is clearly appendix and this is not colon. So I think sometimes it becomes difficult. Prognostically, I think, and this is a little controversial, prognostically for appendix tumors, obviously if it's low grade, then it's quite straightforward. Surgery is a big part of their management along sometimes with systemic therapy. But if it is high grade, then there are several groups in the world that actually will still be very aggressive surgically when it's an appendix tumor, but much less more aggressive when it's a colon primary. So it does have actually prognostic significance or therapeutic significance, perhaps even prognostic significance. But we tend to be somewhat similar in high-grade appendix cancer and high-grade colon cancer. I think we were a little bit more conservative with who we offer major cytoreduction for.
Kiran, I think you brought up a few important points. One is appendix tumors tend to have more transcoelomic spread rather than hematogenous spread to organs. So if you're seeing metastasis to the peritoneum, sometime into the pleura, it may be more appendiceal in nature. The other important point you brought up actually, and this is quite important for the broader community, is that it does require a multi-D discussion about whether we think this is appendix or colon, because the approach, we are typically a little bit more aggressive with local regional therapies, cytoreductive surgery. Even with a higher PCI score, if it's appendiceal cancer, we'll go in a little bit more aggressively compared if it's colorectal cancer. But this requires a multi-D sort of discussion, and that's something we do every week. We have a peritoneal only specific tumor board where these cases are discussed. We have radiologists, pathologists, med-onc surgeons sit down and discuss these cases, and that's kind of necessary to try and pin down what would be the best approach, a personalized approach for each of these patients. Kiran, this has been really great. Really appreciate your expertise here. In the interest of time, we'll move on to the next set of talks. It's my pleasure to introduce Dr. Steve Lattanzi, who's going to talk to us about small bowel cancers next.
Sorry, I was muted. Thank you very much, Raghav. And I will share my screen. Bear with me, please. Here we are. This is a 2026 update on small bowel adenocarcinoma, which definitely qualifies as a rare disease. I was surprised to see, though, that it is more common than anal cancer, which we'll get to in a minute. I'll show the statistics. But first, let me say I, too, have no financial disclosures to make. This is a case.
Steve, I can't see your slides.
This is a case that some of you may recognize from Tumor Board, the GI Tumor Board that we have on Mondays. A 69-year-old woman who presented with nausea, vomiting,
Steve,
and
sorry,
abdominal.
I don't think we can.
Oh, I'm sorry, Raghav.
We can't see your slides. I can't see your slides. I'm not sure if the others can.
Oh, all right. One moment, please. I see what I did wrong. Can you see it now?
There we go. Yes, I think you'll need to. Yeah, perfect. Yeah, you're back to the front, the first slide now. Yeah.
Sorry about that. I will go to my case presentation. Here it is. A 69-year-old woman with nausea, vomiting, and abdominal pain, and was found to have a large mesenteric mass encasing loops of jejunum. There was no evidence of distant metastases, and EGD and endoscopic ultrasound revealed the primary tumor in this case, and ulcerated duodenal mass, which was not, importantly, not an ampullary mass. A biopsy revealed adenocarcinoma. She was thought not to be immediately resectable, although she did not have distant metastasis. And she was treated with palliative chemotherapy, which in this case was Folfox. Bevacizumab was not added because of the risk of small bowel obstruction, which unfortunately she developed anyway while on treatment. A duodenal stent was placed, but her PO intake remained poor and TPN was required. She had stable disease, though, but she did not get a sufficient response to become a candidate for curative intent surgery or even for diverting surgery. At this time, she's continuing chemotherapy. Oxaliplatin has been eliminated because of neuropathy, as often happens with oxaliplatin-containing regimens. And she's stable, but she has not really regained bowel function. That's where she stands at this time. This is the familiar graphic of cases of common cancers from the American Cancer Society statistics that are published every January. And it's just to show us that small bowel cancer is nowhere to be seen on this list. Most of these tumors are adenocarcinomas, and these are the ones we are talking about today. We won't be talking about neuroendocrine tumors, GI stromal tumors, or GIST, and lymphomas, which are also seen in the small bowel. The median age of diagnosis of this disease is in the 60s, and the incidence rates are low. There's a slight male preponderance, as you see here, 0.31 per 100,000 for males, 0.23 per 100,000 for females. And as you see in the little table below, it is actually more common, according to the report, than anal cancer, which surprised me. In my practice, I see more cases of anal squamous cell carcinoma than small bowel adenocarcinomas, but these are the numbers. And I added colorectal cancer just for comparison to show you how rare it is. Risk factors for small bowel adenocarcinoma include celiac disease and inflammatory bowel disease. Both Crohn's disease and ulcerative colitis are associated with an increased risk for small bowel adenocarcinoma. The mechanism here is poorly understood, but the great majority of small bowel adenocarcinomas in patients with Crohn's disease are in the ileum rather than more proximal locations in the small bowel. Lifestyle factors that can increase the risk of small bowel adenocarcinoma appear to be similar to those for colorectal cancer, including alcohol, dietary factors, diets high in red meat and low in fiber, tobacco, although a relatively weak risk factor for this disease, and high sugar soft drinks. Familial syndromes include Lynch syndrome, which is associated with up to an 11% lifetime risk of small bowel adenocarcinoma. And a number of the patients in my practice with small bowel adenocarcinoma have Lynch syndrome. Also Peutz-Jeghers syndrome and familial adenomatous polyposis. These are some of the molecular changes observed in small bowel adenocarcinoma, and you can see that these are similar to what we see in colorectal cancer. KRAS mutations are common. HER2 overexpression is uncommon, and there's a smattering of MMR deficient disease, of course, particularly in patients with Lynch syndrome, and that greatly affects their choice of treatment. Initial detection of small bowel adenocarcinoma can be difficult as the primary site is not often easily identified by EGD. It was in my patient's case, but it isn't always. Capsule endoscopies are often used to detect small bowel pathology, but they can be particularly problematic in cases of small bowel adenocarcinoma due to the risk of small bowel obstruction from the capsule itself. Extensive experience at Yale with endoscopic techniques, including double balloon enteroscopy, which may be effective in establishing the diagnosis. In cases of duodenal cancer, it is important to distinguish them from ampullary carcinomas, which are a different disease and are treated differently. To make the diagnosis of duodenal cancer, the epicenter of the primary tumor should not be at the ampulla, and more than 75% of the primary tumor should not be within the ampulla. The initial evaluation for small bowel adenocarcinoma should include CT scans of the chest, abdomen, and pelvis. A role for PET is not defined here in the absence of equivocal findings on conventional imaging. EGD and EUS is often important for duodenal tumors to confirm the site of origin. CEA and CA19-9 levels can be useful, and all patients with small bowel adenocarcinoma should have MMR MSI testing. Molecular testing is important for patients with distant metastasis, ideally as part of comprehensive molecular testing, but these are some of the genes that at a minimum should be included. HER2/neu, BRAF V600E, and tumor mutational burden and POL-D1 if possible, but ideally as part of comprehensive molecular testing. Management of localized disease is surgical. It involves resection of the primary tumor and regional lymph nodes, similar to colon cancer. An adequate number of regional lymph nodes should be removed. And pancreatoduodenectomy or Whipple procedure is often required for patients with duodenal cancer. If small bowel adenocarcinomas are unresectable, they can sometimes be converted into resectable disease with preoperative systemic therapy. There are small retrospective studies, and I do mean small, which suggest that patients who have a good response to preoperative therapy and can have complete resection can achieve long-term survival. I've given some references below, and you can see when you look at those references, the dates of the studies, which are not recent in most cases, and the numbers of patients are quite small. But this approach can be considered for patients with unresectable disease. Unfortunately, in my patient, it was not successful. Unresectable duodenal cancer patients can be treated with chemoradiotherapy, unlike tumors in the more distal small bowel. This chemoradiotherapy can include 5-FU or capecitabine, and many of these patients may require diverting surgery and or duodenal stent placement, as my patient did. We really, at this time, unfortunately, do not have data from randomized controlled trials to inform our decision of adjuvant systemic therapy for these patients. And the current recommendations are solely based on data for resected colon cancer, which is really a suboptimal approach. I chose before the talk, and I'm sorry to look at my notes, but I chose to look at the NCCN guidelines down in the reference section. For comparison, the colon cancer NCCN guideline includes 1,167 references, of which 947 are specifically about colorectal cancer. In contrast, the small bowel adenocarcinoma guideline, which is a fairly new guideline, includes only 190 references, and only 95 of them, only 50% of them, are specifically about small bowel cancer. Many of the others are about colon cancer, and they're included to show how that data is extrapolated to this disease. Be that as it may, adjuvant chemotherapy is recommended for stage 3 or high-risk stage 2 resected small bowel adenocarcinoma. Importantly, unlike colon cancer, non-inferiority of 3 months of CAPOX versus 6 months has not been established for this disease. Adjuvant chemoradiotherapy can be considered for duodenal cancer that is resected with positive margins, although that too is based on limited data. Adjuvant immunotherapy can be considered for MMR deficient tumors. What is unknown is whether there's any role for adjuvant immunotherapy if immunotherapy was used preoperatively, which can be done in those with MMR deficient tumors. Surveillance guidelines are also based on colon cancer guidelines. In general, these patients are seen for oncologic surveillance every 3 to 6 months for 2 years, then every 6 months through 5 years, and yearly thereafter. CT imaging is done every 6 to 12 months for 2 years, and then yearly through 5 years. Colonoscopy recommendations are simply based on standard surveillance or standard screening, I should say, for colon cancer. For patients with distant metastases, as previously mentioned, all patients should have MMR and MSI testing and molecular testing, hopefully comprehensive if possible. And treatment recommendations, again, are similar to those for metastatic colorectal cancer. While there is a little data here, most of what we do for this disease is based on what we do for colorectal cancer. And I will note with a little bit of puzzlement that there's a lot more data on how to treat metastatic anal cancer than there is for metastatic small bowel adenocarcinoma, even though the numbers of patients with small bowel adenocarcinoma are slightly higher. Active regimens include FOLFOX, FOLFIRI, FOLFOXIRI, 5-FU leucovorin alone, and capecitabine, all of which can be given with or without bevacizumab, although again, the risk of small bowel obstruction has to be considered when adding that drug. Immunotherapy can be given for MMR deficient or TMB high tumors. And there are various targeted regimens that can be used for patients with BRAF mutated tumors. Second-line systemic therapy can include taxane-based therapy, including the regimen paclitaxel ramucirumab, which is supported by evidence from phase 2 trials. HER2-directed therapy can be used for patients with HER2 amplified tumors and KRAS and RAS-BRAF wild-type disease. And targeted therapy options are available for those with NTRK fusions, with RET fusions, and new drugs for KRAS G12C mutations. I included this last line verbatim from the NCCN guidelines that some of these drugs have not been studied at all in small bowel adenocarcinoma, but are included based on the presumed class effect from data demonstrated for other cancer types. That's referring to HER2, NTRK, and RET. Some of these patients have peritoneal disease, and cytoreductive surgery with HIPEC has been used in patients with peritoneal-only metastasis and a good response to systemic chemotherapy. In a meta-analysis, patients who followed this approach could achieve prolonged overall survival. This is something to consider for patients with peritoneal-only disease. In terms of ongoing active clinical trials, there are surprisingly few. There is an open trial of adjuvant chemotherapy. It is a pretty wide-ranging trial. It's known as the Ballad trial, and it's based in France. It's still ongoing. It's expected to continue until 2030. And it has 3 arms: FOLFOX, 5-FU leucovorin alone, or observation. It's open to patients with stage 1 through stage 3, and it even has an option, to my surprise, for patients who do not want a no chemotherapy option, who are convinced that they want chemotherapy or their doctors do. And they have the option of being randomized to the 2 chemotherapy regimens alone. I can imagine that it will be difficult based on these wide eligibility criteria to analyze the outcomes, but we'll see someday what this study brings. This is a trial that's open at Yale for second-line treatment of advanced small bowel cancer, small bowel adenocarcinoma. And it's a 2-arm trial. It's a randomized phase 2 trial, open label, of FOLFIRI versus paclitaxel ramucirumab. Anyone with metastatic small bowel adenocarcinoma is eligible who has either been treated in first line with FOLFOX or 5-FU leucovorin, or has been treated with one of those regimens in the adjuvant setting within 12 months prior to enrollment and has progressed. Prior treatment with bevacizumab is allowed. And the rest is pretty standard in terms of eligibility. Brain metastases are allowed if they've been adequately treated. Importantly, patients with non-measurable disease are allowed. And treatment is continued here until progression or unacceptable toxicity. Unfortunately, one of the barriers to enrollment in this trial is that ramucirumab may be challenging in patients who have or who are at risk for small bowel obstruction. But this is an open trial, and we're actively looking for participants, so please send them along. These are other trials for distant metastatic disease, and there are only a few that I could find in a careful search. The Hoosier Cancer Research Network has a phase 2 trial of first-line NALIRIFOX, another topoisomerase 2 inhibitor containing regimen. This is a single-arm trial. There is a phase 2 trial of pembrolizumab. This is for first-line therapy, and importantly, any MMR status is allowed and any PD-L1 status is allowed. And lastly, a trial in Japan of second-line enfortumab vedotin and antibody-drug conjugate, ADC, in second line, and this too is a phase 2 trial. Clearly, there's lots of room for improvement in data specific to this disease, and clearly it's very difficult to gather. That's my brief overview of small bowel adenocarcinoma, and I appreciate the opportunity to speak, and I'd be glad to answer any questions.
Thanks, Dr. Lattanzi. That was really great. And it is small bowel cancers are really a hard tumor type to treat, and it is quite challenging to get strong data to support this. So perhaps can I ask from a more practical, just experienced oncologist sort of perspective, when you're treating a patient with small bowel cancer, mostly I think we all just flip back to oncological principles to treat these patients rather than hard evidence saying treat them one way or another. What are the factors that make you think I'm going to treat this patient like a colon cancer sort of, or colon cancer-esque sort of patient, versus I'm going to treat this patient as a pancreatic cancer-esque sort of patient? Because I'm thinking about Gemabraxane versus FOLFIRI and those sort of decisions when you're trying to make them. What are the things that you think about when you're treating these patients?
To my knowledge, there is no specific data on the use of gemcitabine or Abraxane in small bowel adenocarcinoma. There is data on taxanes, and the studies I'm thinking of include paclitaxel alone or with ramucirumab. But to me, the choice of such a regimen would depend mainly on the location of the tumor. It's tumors in the duodenum and tumors that are proximal, one would believe be more likely to respond. But honestly, there's very little data. And I think the majority of these patients will eventually see both a taxane and a fluoropyrimidine-based regimen.
Yeah, I think that's fair. I mean, I think the question came more along the lines of the trial that you were designing, where PACRAM is more upper GI cancer sort of regimen, whereas FOLFIRI is more a lower GI. I mean, we use it in upper GI cancers as well, but it's typically considered more lower GI, and that was essentially the equipoise that was placed for which this trial was designed around. And so I was just thinking about what would I use to decide one regimen over another, and this trial hopefully will answer that question quite nicely. We do know that these cancers do have an element of response to VEGF inhibitors in general, because we use them in colon as well as upper GI cancers. But like you often said, it's hard because of the intestinal obstruction issues that we face with these patients. Could you talk to us a little bit about what are the supportive care needs that these patients have? Because very often they're going to have nutritional issues, they're going to have other ascites and other things that they may need, and what you might think about to take care of these patients.
Sure. These patients commonly have bowel obstruction. In that sense, they can behave like other tumors with advanced peritoneal disease, certainly appendiceal carcinoma, ovarian cancer, and others. Enteral nutrition can be difficult or impossible. Stenting can help, but it's very difficult for distal tumors. If the anatomy is favorable, bypass surgery can be considered. But unfortunately, as these patients progress, that is the kind of thing that gets more and more difficult to manage.
Yeah, so you're absolutely right. I think because of the obstruction issues, very often we will need advanced GI to come in to help us discuss, depending on if it's more proximal tumors, duodenal, whether they need stents. Often different sorts of endoscopic ways of bypassing obstructions are considered nowadays. Whereas at the same time, surgical oncology input to help with any of the more complex bowel obstruction issues are also very valuable. So I think that's again reiterating the need for multidisciplinary care for a lot of these patients. I don't see any other questions on the chat group. Maybe I'll end with a more broader question, which was asked by one of the audience about whether we think about immunotherapy as being more additive to our systemic therapy options rather than being synergistic. And this is gradually increasing in the GI cancer spaces compared to lung cancer and other spaces where the immunotherapy has taken off in a bigger way. Thejal, what are your thoughts about this comment?
Yeah, it's a good question. I think, the tumor microenvironment for a lot of our GI cancers and the immune infiltration in that setting is, maybe not quite as robust as in some of these other cancers where we do see the use of single agent immunotherapy much more successfully. And so right now, primarily when we're using single agent immunotherapy, it's for patients who have MMR deficient disease or MSI high or very high tumor mutational burden, which we have seen great success for example, with the dostarlimab study in rectal cancer, et cetera. But in general, in other settings where the comment is absolutely accurate that we are using it more so additive rather than a replacement, other than sometimes more so in the palliative and second line settings, et cetera. But happy to hear what others have to say too.
Yeah, I mean, I think if you think of it from very scientific or from a very scientific perspective, that may be true. But at the end of the day, the fact is when we're dealing with GI cancers are typically a lot harder to treat. Patients are coming in sicker. And the truth is chemotherapy and immune-targeted therapies almost always end up with progression of disease at some point of time. Immunotherapy is the only drug that there is even a small chance of long-term survival. And so while this may be additive for patients on the ground, if we have a chance of giving immunotherapy, we're going to try and give it, and giving it early and giving it in combination with giving it upfront where they have a longer and better chance to respond to it is always going to be something that patients are going to want, and we would want for our patients too, even if there is a 10-15% chance of long-term survival. And I think folks like Dr. Turaga can attest to this. There are folks who will be like, you don't have any hope of getting surgery, and 6 months with immunotherapy, and they're seeing Dr. Turaga and trying to get all their tumors cut out. And I think that's something that you will not get with anything else apart from immunotherapy. And so I wouldn't play down the additive effects that immunotherapy may have for a majority of the patients. I don't know, Dr. Lattanzi, Dr. Turaga, if you have any thoughts on this.
I mean, I think the promise of this dramatic response that immunotherapy has is just so incredible. And I think you said it well. It is something that is exciting in the armamentarium. I mean, I wish we could have more patients respond well to immunotherapies, and I think it's something to keep our fingers crossed for. But no, I agree with your comment.
Great. This has been a really fantastic discussion across multiple tumor types and different areas of research interest and the frontiers that we're pushing in different spaces here. I'm going to thank everyone for your time and attention, and thank the panelists for great talks, and have a great evening, everyone. Take care.